What are the factors responsible for PIH? So, vascular remodeling is incomplete in some patients. This could be due to immunological factors, genetic factors, environmental factors, and some role of complement activation, as in SLE and APLA patients, which increase the risk of developing preeclampsia. Now, what are the immunological factors? Normally, maternal immune system develops a tolerance against the paternal antigens and the fetal antigens. This is known as the immune tolerance that occurs in patients normally, and this occurs with the help of lymphocytes, where T helper 2 lymphocytes increases more than T helper 1 lymphocytes. But this lymphocyte shift does not occur in patients with increased risk of preeclampsia, and the lymphocytes are the regulatory T cells, residual macrophages, residual natural killer cells. Most importantly, these cells do not only helps in developing immune tolerance, but also play a role in vascular remodeling and trophoblastic invasion. So, if there is loss of immune tolerance, then PIH occurs. And this is the basis of immunological theory of preeclampsia. Now, what are the evidences? For example, first time pregnancy or the primary gravida female, or a pregnancy with new paternity or long interpregnancy interval. So in these conditions, there is increased exposure of paternal and fetal antigen, usually for the first time, that leads to increase in the risk of preeclampsia. When there is paternal genes or more like in molar pregnancy, then risk of preeclampsia increases in molar pregnancy. Trisomy 13, where there is 30 to 40% increased risk of preeclampsia, because trisomy 13 is having trisomy of chromosome number 13, which has a gene for SFLT1, and hence in females with trisomy 13 there is overexpression of SFLT1 and increased NK cell activity. This is not in females with trisomy 13 baby. This is in females with trisomy 13 itself. There is increased risk of PIH in IVF, ICSI, and long interpregnancy intervals also. T helper cell shift we have already discussed. T helper 1 cells are decreased in pregnancy, and normally T helper 2 cells are increased. There is humoral immunity increased, while T helper 1 cells produce inflammatory cytokines which are reduced, and these T helper 2 cells help in immunotolerance, known as Th2 bias. In patients with preeclampsia, from the beginning of the second trimester, Th helper 1 activity increases while Th2 activity reduces. Now, what are the genetic factors that predispose to preeclampsia? Preeclampsia is a multifactorial polygenic disorder, and a group of genes is responsible for PIH, which is not just maternal paternal genes, but also linked to fetal genes. The fetal genes which could be possibly linked to PIH includes HLA-DR4, interleukin 1b, polymorphism in TNF, and lymphotoxin. If there is family history of preeclampsia, then if mother is having history, then 20 to 40% increase, sister 10 to 35 pregnancy, and 22 to 45% increase in twin pregnancy. Hence, both past and family history are important. Now, what is the role of ethnicity and racial factor? PIH is more common in African American females and increase Latin American females. And environmental factors like obesity and hypocalcemia are also the risk factors. The immunological, genetic, environmental factors play a role which changes the phenotypic expression in preeclampsia, causing an ischemic placenta, and hence this is the main culprit for preeclampsia. So, if the placenta is removed, then this is the treatment of preeclampsia, means the management of PIH. Definitive management is the termination of pregnancy.